Hi everyone, I'm Dr. Max Gomez, and I'd like to welcome you to today's edition of the National Kidney Foundation's Facebook Live series. Now today we'll be discussing the connection between two of the most important organs in your body, the heart and the kidneys, and how to keep them both healthy by lowering your risk for heart disease. I'm pleased to be joined today by Dr. Les Spry, who's a nephrologist, or as he likes to refer to himself, a kidney guy.
Kidney guy? A kidney guy, that's what it is.
Okay, good enough. And Dr. Michael Miller, a cardiologist, and can we call you a heart guy then?
You can call me a heart guy.
A heart guy, okay, good enough. And to represent the patient's point of view, we're very happy to be joined by Anna Norton. Hi, Anna, the CEO of the patient advocacy group Diabetes Sisters. She has diabetes and has a great interest, of course, in helping herself and others protect their heart and kidneys. Now, our guests are all here to help us understand an important topic that many misunderstand. So thank you all for joining us today. You know, it's important to understand the connection between heart disease and kidney disease. After all, your heart and kidneys are vital organs that you can't live without. They work together to keep you healthy, and when one is affected, the other is too. So simply put, the heart affects the health of your kidneys, and your kidneys affect the health of your heart. We're going to talk more about how that connection works. So whether you or someone you know has kidney issues, heart issues, or perhaps a bit of both, I hope that today we can help you learn how to lower your risk for heart disease, which will also help your kidneys. So let's start out, Anna, with you. Obviously, you have diabetes, and I'm sure that you've been told that that has somewhat of an impact on your kidneys, and I'm sure you've seen all the television commercials, right? Where they tell you diabetes affects your heart as well. So let's start out with you, because here's a chance for you to ask the experts a little bit here. What are some of the questions that you or some of your friends have that want to know about this connection between the heart and the kidneys?
Yeah, thank you, doctor, and thanks, docs, for being here today to answer some of these pressing questions that we have. I've lived with diabetes for 26 years. And more recently have learned a lot about the connection between heart health and kidney health as it pertains to diabetes. I would really like to know, what recommendations do you have for me, a patient living with diabetes, and other people that live with diabetes, about how do we best protect both our heart and our kidneys while living with diabetes? And what's the relationship between those two organs in our body?
Well, as you know, the diabetes is one of the major risk factors for kidney disease. It is the #1 cause of end-stage kidney disease, or the requirement for dialysis in the country today. And so what we recommend is that since we know it as a risk factor, we recommend at least annual screening for things like blood tests. We're looking specifically for a kidney function test known as the glomerular filtration rate. And secondly, we're looking for a urine test that specifically deals with protein in the urine. Those two tests help us to figure out whether or not you have kidney disease and what treatments might be engendered there. Now, risk factors for heart disease, Dr. Miller can elucidate.
Sure. So Anna, you've had diabetes for a fair period of time, but the good news is that you could still make significant changes, both in your lifestyle and with medications, to reduce your risk. We know that diabetes, the risk of heart disease, does go up. But we also know that if you pay attention to some of those other risk factors that may be associated with diabetes, two of them are blood pressure. So if high blood pressure, if you control blood pressure, then it also has a beneficial impact on your heart. And also if you lower your lipids, which are cholesterol and triglycerides, they will also both help to reduce your risk of heart disease and kidney disease.
So we tend to think of heart and kidney as kind of separate things that sort of operate on their own, but there really is a very close interrelationship between, if you've got something wrong with your kidneys, it will affect your heart and vice versa. Tell me a little bit about that connection.
Yeah, I mean, there's an important connection, because we know that the heart has to pump effectively, and if it doesn't pump effectively for a variety of reasons, if you have heart failure, for example, then that will have an adverse effect on kidney function.
Absolutely. I tell my patients that I just supply the statement that if you had better kidneys, you'd have a better heart, and if you had better heart, you'd have a better kidneys. And that interaction I see all the time, because the kidneys and the heart really do have mutual risk factors. They actually have mutual treatments, and the evaluation over the long course of time has to include both areas.
And kidney disease, or the kidneys, are intimately involved with regulating blood pressure as well, which has that impact on the heart. Tell me about that.
Absolutely. As we develop kidney disease, the complicating feature there becomes high blood pressure. We frequently, as kidney disease progresses, there can be loss of protein through the kidneys. We know that that loss of protein can sometimes reach proportions that result in something called the nephrotic syndrome. That occurs commonly in diabetes, actually, where people are losing large amounts of protein. This results in the nephrotic syndrome, which raises your lipids and actually is associated with a markedly increased risk of heart disease and atherosclerotic disease. We also know that kidney disease causes high blood pressure, and as we treat that, we know that certain selective medications actually benefit both the heart and the kidneys.
Good. And I saw you scrunch your nose a little bit when you heard protein in urine, and I think most people, you probably understand this because you've been around it long enough. I think a lot of people are a little confused when they hear protein in the urine.
So I mean, I would love to better understand what protein in the urine is. What does that mean for a lay person or a person who's just been diagnosed with diabetes, or who's just hearing this after 5 or 10 or 15 years with diabetes?
The kidneys are responsible for handling and filtering the blood. And so I usually tell patients it's sort of like a spaghetti strainer. So it turns out that your kidneys are kind of like that. You boil spaghetti, dump it in the strainer, water falls through, spaghetti stays on the inside. Well, it turns out that diabetes, high blood pressure, other things can actually shoot holes in that strainer, and so that the protein tends to leak out, the spaghetti or the protein tends to leak out. And one of the early proteins that does that in diabetes is something called albumin. We sometimes see it referred to in the urine testing world known as microalbumin, but it's really just albumin that leaks out into the urine. And when we see that, we know that that's the earliest sign that there is diabetes affecting the kidneys. And as I said, once we see that, then we know that there are certain medications that we use to treat both the heart risk and the kidney risk.
Great, thank you.
I don't know, Dr. Miller, if you've got a similar thing as spaghetti in the heart, but what else? So how do you protect the heart, in ways that will not only protect the kidneys, but not have an adverse effect on the kidneys? Because a lot of us, we forget that some of the things that we might do that might be good for the kidneys might actually not be great for the heart, and vice versa.
Right, so I think there are a number of medications, as Leslie pointed out, that do protect the heart and they do protect the kidney. Also medications for high blood pressure, medications for high cholesterol. We want to keep cholesterol and triglyceride levels down, because if they are too high, then you run into the risk of causing inflammation. So you have inflammation in the blood vessels, and some of the blood vessels in the kidneys can be problematic, and you have what we call oxidative stress. And so all those things add up. By not controlling each of these risk factors, they do add up, and they could promote kidney disease and heart-related problems.
What do you do to protect the kidneys? We talked about what some of the damage might be. How do you protect your kidneys?
Well, so as I mentioned, there are certain medications that benefit both heart and kidneys, but the first thing I usually talk to my patients about is, number one, what is the cause of their kidney disease? And if it is diabetes, it's very careful control of diabetes. Trying to keep your hemoglobin A1Cs under control. Your endocrinologist will give you targets, usually, for what you want to be there. You want to keep your blood pressure monitored and under control, and we generally like blood pressure control to be very good. We even talk about 120 over 80. We want blood pressures to be normal in the case of diabetes. We want you to be on a good diet. We want your weight to be down and controlled. We want you to be increasing your physical activity over the course of time, because that results in increased sensitivity to insulin, but it also results in lower blood pressure. And all of those things are things that you can do without me writing a prescription. But once we get to prescriptions, then we start talking about things like ACE inhibitors and ARBs and things like that that directly impact the way in which the kidneys work, so that our goal is to try to decrease the amount of protein that your kidneys are leaking.
So the first thing you want to do is find out what might be causing that what's the underlying cause, whether, as you said, it's high blood pressure, some of these other issues that's in there, and then you move on to see, because there is kidney disease that you really can't find a cause for necessarily?
Well, yeah, in some cases, we have kidney disease that we don't know what the cause is, and we don't have an association like diabetes or high blood pressure or heart disease. And in other words, we see atherosclerotic disease causing heart disease and kidney disease together. But once we see that we don't have an explanation for that, we'll frequently do a kidney biopsy so that we actually can look at the histology of that. It's a little harder to biopsy the heart, but we can biopsy the kidney, and we can get good ideas as to why that person has kidney disease, and then that leads to more direct treatment. What we're talking about here today is more general treatment for protein and loss of kidney function and its association with heart disease.
So let's talk about the heart now, okay? What are we going to do? Because I think a lot of us know lower your blood pressure. Usually it means less salt than we tend to consume, and statins. Those are kind of the go-to.
That's the kind of the mainstay, but it's not that while they may be necessary, they're often insufficient. And that is because we have the so-called, in many of our patients, diabetic patients, patients with kidney-related issues often will have so-called residual risk, which means some degree of elevation in LDL, the bad cholesterol, some degree of elevation in triglycerides. Now, cholesterol and triglycerides are different. Cholesterol is a waxy substance, triglyceride is fat. But both of them, when you combine them, they both could be problematic to the heart, to the blood vessels, and to the kidney. So the idea, let's mention a blood pressure of less than 120. But some of these other numbers, blood glucose, you perhaps want to keep it below 100. The LDL, the bad cholesterol, you want to keep it below 100 for sure. Triglycerides, an ideal triglyceride is less than 100. So maybe if you want to lift to 100, you get all those numbers below 100.
But you make a good point, because these numbers have sort of, the target numbers have been trending down over the years. I mean, I remember when, 200, 250 for cholesterol was considered, no, that's okay, that's normal.
And you would take somebody's age, I remember, and you would add 100 to that. And that was, so if you were 50, 60 years old, you had 100, that was a desirable upper limit for blood pressure. So it could be 150, 160.
And now we know that ain't so good.
It ain't so good.
It ain't so good. So you mentioned triglycerides and you mentioned cholesterol. They're really separate and independent risk factors. In other words, you can have your cholesterol down to the target range, and if your triglycerides are high, you're still at risk?
Absolutely. So, and this, a lot of people, a lot of my colleagues really didn't appreciate this, but studies have now shown that even if you have a good LDL, good level of the bad cholesterol, having an elevation in the triglyceride level is still associated with increased risk.
Can you do something about triglycerides?
Well, you can. Triglycerides are number one responsive to lifestyle. So if you're overweight, getting the weight down, reducing simple sugars and saturated fat helps, exercise help. And then we also have some ways to get about it with medication. There was a study that called Reduce It that used a highly concentrated omega-3 EPA called icosapentaethyl. And this was studied in men and women who had diabetes or had high risk of heart disease or had heart disease, and on top of standard of care, which would have been the medications that they used to treat statins and blood pressure medicines and diabetes medicines. On top of that, if they were placed on this icosapentaethyl, they had an additional 25% reduction in heart attacks and strokes.
That sounds pretty big. That's important. So you've got to pay attention to both of those numbers. So, Dr. Spryer, are any of these interventions, whether medications or otherwise, that you might do for your heart not great for the kidneys, or that you might have to think twice about?
Well, so it turns out that the kidney disease by itself is associated with an elevation in those triglycerides. In other words, the fact that someone has triglycerides, as someone develops a retention of these substances from the kidney failure, hypertriglyceridemia, or an increase in the blood triglycerides, is a common concomitant of that.
That might be a warning sign that something's going on in the kidneys.
We frequently see that in laboratory testing. When I have students and other people showing me laboratory testing, if I see elevated triglycerides, one of the things we ask them about is, do they have kidney disease? Because usually for typical familial hypercholesterolemia or
high
even
cholesterol.
the high cholesterol that's associated with genetic defects and things like that. That's typically elevated total cholesterol and elevated bad cholesterol. What we frequently see in kidney disease is the opposite thing. We see a lowering of the good cholesterol, which is not good, and we see an elevation in those fats. And that creates more hardening of the arteries, if you will, in our patients with kidney disease. And so we know that our patients with kidney disease have this increased risk. And so treating lipids, increasing exercise, using appropriate drugs for blood pressure control, keeping your weight down, and following good diets. I recommend DASH diets myself for many of my patients that are on that have kidney disease. DASH diet tends to help in multiple areas as far as salt reduction and increasing the amount of fruit and vegetables in the diet and decreasing red meats in the diet. Those are the main things.
And that's something you can Google, DASH, D-A-S-H, and that'll give you what the whole
DASH and NIH. If you Google DASH and NIH together, because it's a diet developed by the NIH.
Right.
And I also want to point out, on top of, you look at the kidneys in people with high triglycerides, try having a high triglyceride can also predict the development of diabetes down the road. And over the years, I've had a number of patients who've seen me 10, 15, 20 years ago that had triglycerides in the 3, 4, 500 range. Again, a normal triglyceride is below 150, below 150, ideally below 100. And those individuals turned out to develop diabetes later in life.
Now, my understanding also in some of the reading that I've been doing now is that some of the interventions, for example, statins, that might lower your cholesterol, might actually push your triglycerides up?
By
Or
and
has a
large,
kind of a
yeah,
plus and
it
minus?
may have a plus-minus effect. I mean, we do see some reduction in TG sometimes. The problem is sometimes patients will go on a statin and say, I don't need to worry about my diet. And so they loosen up on their lifestyle, and we do not recommend that.
Of course.
So you're taking my ice cream away from me?
You could have ice cream once a week.
And the Kidney Foundation recommends meatless Mondays too, by the way.
Meatless Monday is ice cream once a week. All right. Can I use it? I'll do it tonight. All right. Very good. So there's some other medications, Dr. Spry, that we talked about earlier that might be okay for the heart, but aren't so great for the kidneys. And some of these are some of the pain relievers that all of us often take.
Absolutely. We find that patients, we want them to avoid certain non-steroidal agents, we call them. They're things like ibuprofen, Motrin, Aleve, Advil. Those kind of medications, the kidney has relatively no resistance to. And if we use those medications, those result in a raising of the blood pressure, which could impact heart disease. It results in certain blood pressure medications like my ACEs and my ARBs not being effective, and it directly decreases kidney function as an action on the kidney. And so nonsteroidals are not our favorite drugs. It turns out that aspirin, the kidney does have the capacity.
Which is also a non-steroidal.
Yeah, aspirin is a non-steroidal, but it does not have, the kidney has the capacity to overcome aspirin within about 30 minutes. Or Tylenol or acetaminophen is a safe medication for kidneys as long as we keep the doses down so that we don't impact your liver. No more than about 6 or 8 tablets a day. If you're using extra strength, no more than 6 of the acetaminophen can be helpful in pain relief, but for an anti-inflammatory, that can be a problem.
Because I hear this from patients as well. You know, I get up in the morning, I'm getting a little older, everything's creaking, or I've got a headache, and I'm not supposed to be taking these anti-inflammatories. What do I take? But what you're saying is short-term, or there are these alternatives, aspirin or acetaminophen might be okay.
Or topical rubs. I must tell you that I find patients get more relief sometimes in topical rubs and certain stretching exercises as well as the topical rubs that relieve pain without messing with my kidneys or the heart.
Right. Hard to use for a headache, though.
Yeah.
But stretching is important, and getting up and being active is important. And we recommend getting up at least twice each hour if you're at a desk job.
Anna, what else is there that you might want to ask these gentlemen?
I actually have a question about the omega-3 fatty acids that we were talking about. There are some that are prescription. There are some that are over the counter. And then I know that we read a lot about foods that are rich in the acids. So what is the recommendation for people in general that are trying to protect their heart and their kidneys when it comes to these? So what's the difference between a prescription or an over-the-counter, and then can we supplement with the foods that we're eating?
Right, so first, I mean, if you eat marine-derived fish like salmon and sardines and so forth, they do have triglyceride-lowering effects. The prescription form of omega-3, I already mentioned the icosapentaethyl, will lower triglycerides upwards of 20 to 30%. What you said over-the-counter is really not over-the-counter, they're supplements. Over-the-counter, this is important because if you look at over-the-counter medications like Tylenol, it's regulated by the FDA. Supplements are not regulated,
right.
so you don't know what you're getting. One of my colleagues has done a lot of research in this area and has actually analyzed these capsules and has found upwards of 1/3 of each capsule contains, each capsule contains about up to 1/3 saturated fat. So lots of saturated fat, other garbage or toxins that you certainly do not want to consume. I do not recommend supplements.
Okay.
Because you don't really know, since they're not regulated, you
don't know what you're
really
getting.
know what's in there, and that's a good lesson to take home.
Thank you for that. So we shouldn't be going to Costco and buying the 180 tablets
I
of the
would not recommend it.
Fair, thank you.
And not just Costco, by the way. So at this time, let's take a few minutes to answer some of the questions from you folks, from folks tuning in. And if you have any questions on this subject, please go ahead and post them in the comments section, and we'll try to do our best to answer as many as we can. If we run out of time, all of your questions will be addressed on the National Kidney Foundation's Facebook page after the program, so don't worry, we'll get to them. So here, let's see. Okay, here's the first one that we've got coming in for Dr. Miller. Do you have any advice on diet that can help both the kidneys and the heart? We mentioned the DASH diet. Is that okay as well?
Yeah, DASH diet is fine. So obviously you want to reduce sodium, but also reducing, we mentioned the bad animal fats. Bad animal saturated base foods. Small amounts might be okay, but really trying to restrict the amount of saturated fat and reduce the amount of sugars. So soda drinks, for example, would be two simple recommendations. And also the other thing I recommend in general is to try not to eat too much before bedtime. So what I advise my patients is typically after dinner, hopefully dinner is about 4 hours before bedtime, take a walk.
Mm-hmm. The lesson also that I think people maybe need to take home from this is because they figure that it's all about taking everything away from you. And it's okay, right? Moderation, ice cream once a week.
Once a week,
like
moderation and smaller amounts.
Right.
I mean, we're used to just, eating everything. Your mother probably told you to eat everything on your plate. But if you go to Okinawa, they usually know when they're, I don't know how they know this, they know when they're 2/3 full or 3/4 full. So better to go to bed feeling a little bit hungry than feeling too full.
Yeah, too full is, and also as a victim, shall we say, of reflux, going to bed with a full stomach is really not a good idea. So moderation in everything, including moderation once in a while. So let's see, we've got here, Dr. Spry, are there any symptoms associated with high cholesterol or high triglycerides? Because we talk about symptoms for other things. We know when something's wrong, but will we know?
It turns out we don't, and it's the case both with kidney disease as well as high blood fats and cholesterol. They're usually associated with no symptoms. Now, there are certain symptoms that, if present, signify very high fats, and those are things like pancreatitis. We will see some patients who have acute pancreatitis. It's commonly associated with alcohol ingestion as well, but the ingestion of alcohol associated with kidney disease and with high blood fats, one can see acute pancreatitis, and that can be a very significant illness. Secondly, patients do get very, very high cholesterol sometimes when they have kidney disease, and you can get changes in the eyes, for example, as a result of that. So there are eye changes that you can see, not necessarily symptoms, but certainly things you can examine and know that they're abnormal.
But in general, not a lot of signs or symptoms. And Dr. Miller, we get the same thing with high blood pressure, right? You generally don't know that you've got high blood pressure.
I mean, sometimes you might have a headache, for example, or blurred vision. So oftentimes these are silent until they,
get to really get to
have a problem until you have a problem. So, but you need to be cognizant, and if you do have high blood pressure or glucose or sugar-related problems, then monitoring them on a regular basis makes a lot of sense.
So here's a question that I haven't heard of this in an awful long time. Cod liver oil. Is that's still around? People are still taking cod liver
Yeah.
oil? Is that a good idea, bad idea? What's going on with cod liver oil?
Well, I mean, it was
grandmother
used.
used to take
Yeah,
it.
I was going to say, I think grandmothers universally would recommend it. You do get with about a teaspoon's worth of cod liver oil, you get a fair amount of vitamin D and vitamin A. You don't want to go too much above that because it could be problematic. But I don't recommend that. I mean, I would recommend natural sources. Get the sun, 15 minutes of sunshine, under 10 a.m. or above 3 or 4 p.m. So you get the less sun
It's a
radiation
skin
damage.
cancer issues, right.
But so you can get it through. You can get D, and you can get A from other ways. I don't recommend.
So, and actually, that's the other question, because you already said you don't recommend supplements. Are there any supplements either one of you might recommend?
Well, if someone has a balanced diet, I don't know that supplements are necessary. I would say that there's occasionally supplements that people want to take, especially if they're experiencing symptoms related to their kidney disease and their natural intake is declined. But if someone's following a good DASH diet or a diabetic diet, in many of those instances, you don't need a supplement. Now, a multiple vitamin, if you're having some issues with your intake, or especially if you're having weight loss, is something that I will commonly recommend in people who are losing weight. But if you're otherwise stable, I don't know that supplements are necessary.
You agree?
Oh, I agree, unless you're in a deserted island and you can't get. But short of that, as Les points out, I think it's not to your benefit. And some studies have suggested that some people may be susceptible to certain kinds of cancers from these vitamins because they can promote some cell division.
Right. So here's something that I hear a lot, both with heart disease, sometimes with cancer especially. I don't have a family history of heart disease or kidney disease or cancer, for example. My cholesterol seems to be okay. I'm good. I'm out of the woods. Fair?
Not necessarily. I just had a patient. I just had a patient yesterday, who's in his 50s, and came to see me because no family history, but they happened to do a scan on him, and it had a coronary calcium scan. Now, a normal scan is minimal,
right,
and a 55-year-old person should be less than 10 or so. It should be 0, actually. His was 2400. 2400. So family history will help you, but if you don't have the family history, it doesn't necessarily mean you're out of the woods.
Right. I've had cardiologists tell me if you've got a heart, you're at risk.
Right.
Especially with the stress that we have on a day-to-day basis.
And our lovely Western diet. Same thing for kidney disease?
Certainly. We know, for example, that heart disease is the most common cause of morbidity and mortality in the United States today. But we do know that if you have heart disease, kidney disease is a common concomitant of that. And so if you don't have any history and if you've never been screened, we do recommend at least screening with that blood and urine test that I mentioned earlier. Beyond that, if you've had at least one screening test, then that's usually sufficient. However, if there's any family history, or if you have any history of high blood pressure, if you've never been screened for cholesterol, all of those things are important. Those are part of what we call primary care or preventative health care. And we in this country need to spend a lot more time in preventative health care than taking care of people on dialysis like I do.
Boy, isn't that the truth? And I also often hear, and this is something I think we were talking about right before we got started, is you're taking care of people with kidney disease, but heart disease is much more likely to be the thing that's going to take
Absolutely. When I get somebody in my office who has kidney disease, they want to know what pill I'm going to give them for their kidneys. And I tell them, you're statistically much more likely to suffer complications of your heart just because of how common that is than you are of kidney disease. In fact, for older individuals, it's much more likely they're going to die of heart disease than they actually will to go on to dialysis. And that's true of most of our patients. Now, younger and they have certain diseases that are not diabetics or that are, we have certain types of what we call glomerulonephritis or nephritis kinds of things. Those kind of folks are less likely to have heart disease, but over the course of time, they may also get heart disease as well.
Mm-hmm. Let's go back to that one point that you made that I think is really an important takeaway here, which is prevention. Because I hear again from a lot of people saying, I don't like to go to the doctor, I don't want to take medicine, they're going to wait until it's broken before they try to fix it. At that point, it may not be easy or impossible to break. So prevention.
Prevention is key, and the good news is even if you've experienced an event, we could do a lot by making changes in our lifestyle. It's never too late. Never too late is an important message. So secondary prevention is preventing recurrent events. Primary prevention, preventing the first event. And there's a lot of information, a lot we can do to prevent both.
And in order to do that, you need to know some of these numbers that we were talking about. Your cholesterol, triglycerides, blood pressure, blood sugar, all of those are important to know, right?
And it's relatively inexpensive to screen somebody and do preventative health care. It costs $70,000, $80,000 a year for me to have somebody on dialysis. So doing that up front is a lot cheaper than having me treated at the end. So pay me now, pay me later kind of stuff.
And heart surgery ain't cheap
Heart
either.
surgery, stents, and the medications, and all loss of work and productivity all adds up as well.
That's it. There's our take-home message for today, right? So it looks like we've reached the end of our time here tonight. In case we didn't get around to answering your question, please check back on the National Kidney Foundation's Facebook page, where we will be posting the answers throughout the coming days. And now, on behalf of the National Kidney Foundation, I'd like to thank our sponsor, Amarin, and for their generous support in making this program possible. And I'd especially like to thank Drs. Spry and Miller for their time and expertise. Thank you guys in discussing this very important topic, as well as, of course, our patient, Anna Norton, for taking the time to share her very helpful insights and experience. So until next time, I'd like to wish you all good health.